Well, good afternoon, everyone. I'm Dr. Richard Ferguson, President and founder of Black Physicians of Utah, and happy you could join us this afternoon as we have an informative discussion about Black maternal mortality rates. And particularly, this discussion is important because in our nation, the rates are not decreasing for those of Black mothers giving birth, but actually they're increasing. This afternoon, we'll be joined by a Black doula, a midwife and nurse practitioner, and also a maternal fetal medicine fellow, who I will now go and introduce. So we have here representing from U of U Health, Dr. Ade Adesimo, first-year fellow maternal fetal medicine. Nice for you to join us this afternoon.
Thank you for having me.
And then we have Jalon Fall. She is with Birth Care Healthcare. She's a midwife nurse practitioner, also with U of U Health. And then we have Sacred Sister doula. We have Ashley Finley of Sacred Sister Doulas.
You can say Sacred Sister, that's fine.
Okay, all right. So I'm going to start off by first having a little bit of an explanation of what does a Black maternal mortality rate mean? What is associated with sometimes that loaded term, even going to the point of maybe we should have to explain a little bit of what is meant by mortality. So to get us off here, to have this constructive conversation, but also the point here is to provide advice to not only healthcare providers, but also to you, the public, so you can do what's best to advocate for your own healthcare. All right, so Dr. Adesimo, what is maternal mortality?
So maternal mortality can be defined in a number of ways. I think what we think of most commonly is a maternal death or the death of a pregnant or recently postpartum woman. Typically, postpartum is up to about 6 weeks after a delivery. There are a number of different definitions that might include longer periods of time. Some of the definitions include causes of maternal deaths that are incidental or accidental, not necessarily directly related to the pregnancy. But I think when we generally think of maternal mortality, we think of pregnancy-associated deaths of a pregnant or postpartum woman.
And what are examples of, say, the top 3 causes for maternal mortality? What's causing the loss of life for these women?
So there are a number of different causes for maternal deaths, for the unfortunate event of a maternal death. And the causes vary by region, where you are in the world, also where you are in the United States. But in general, the most common causes of death include causes related to cardiovascular or heart conditions. A cause of death during pregnancy or during a delivery can typically be associated with excessive bleeding at the time of a vaginal delivery or a C-section. And then other causes include infectious causes. So if you have an infection after a surgery, and I would say to round out the list, there's also causes of death from high blood pressure.
Okay, so someone with the condition of hypertension, if it being undiagnosed and she's pregnant, that can lead to her having a poor outcome during delivery, but also after?
Exactly. Actually, a lot of the deaths and morbidity that come from high blood pressure disorders of pregnancy do occur in the postpartum period. So it can occur at any time in pregnancy, both during and immediately after.
Okay. So what is the rate of maternal mortality in the United States?
So the rate varies year by year. Most recently, the rate was about 20 per 100,000 births, which basically means that for every 100,000 births that happen in the United States, 20 women die from pregnancy-related causes. Wow. In that year.
And so why is this rate increasing in the U.S.?
There are a number of factors that people are positing or postulating as to why the number is increasing. And there's no one surefire explanation. I think that a couple of different reasons. One is that we are potentially taking care of a sicker population of patients, not only just from a health perspective, but also there are a lot of women that are having pregnancies at later ages than was done in the past. So that's one potential cause. The other causes include increased ascertainment. So there's been a big
What does
push.
that mean?
There's been a big push to get better at trying to figure out when these actually happen. So we weren't always well equipped to keep track of maternal deaths. And there was possibility that deaths were occurring and they weren't being tracked or noted. So there's been a big push to not only keep track, but also review maternal deaths. So some think that that has also, the ascertainment that I just mentioned, just keeping a better track may have also led to what we perceive as an increase in rates. I think irrespective of what's going on, I think a maternal death is a very serious consequence. And whether the numbers are changing for X, Y, or Z reasons, I think that the facts need to be reckoned with and we need to figure out how to make some changes.
So it's almost similar to how ADHD or autism seems to be diagnosed more, but compared to, say, 40 years ago, we didn't really have the guidelines or the appropriate tests to pick up or know how to screen. And now we're better at data collection in the internet age. And then we have data being pulled from several hospitals all going into one collective database that probably wasn't present in the 80s.
Exactly.
Okay.
I think it's important to also, not just look at the overall rates, but also the absolute numbers. So I think it's important for women to know that in the United States, taking the year 2020, for example, roughly 850 women in total died as a result of pregnancy-related causes. And that's out of about 3.5 million births. And I think it's important to make that comparison to other nations globally. For example, sub-Saharan Africa, there was around 200,000 deaths. That's the average annual number in absolute terms in comparison to the 860 I mentioned for the United States. And the number one cause of deaths in that region is excessive bleeding at the time of delivery, which most people consider to be something that can be prevented or corrected. So with blood transfusions or medicines that help women not bleed as much during a delivery. So I think that discrepancy just really hits home the importance of resources and the fact that a lot of these deaths are potentially preventable if the right resources are in place.
To talk to you a little bit there, Ashley, how can Black doulas reduce the Black maternal mortality rate?
I think in my work, at least I can say personally, a Black doula is helpful because not only are we understanding of certain like cultural attitudes towards healthcare and experiences in healthcare, but we can also, I like to think of myself as kind of like a liaison, as like, between like a healthcare provider and a client. Meaning, so when a person is talking to their healthcare provider, sometimes there can be a bit of a disconnect and maybe information can be lost. And so I like to think of myself as kind of the translator between the two that can help advocate for people to like make the decisions that are best for them, to remember to ask the questions that they want and need to ask, to also help remind providers to explain what they're saying, maybe, and like more common language, those sorts of things. A doula is a non-medical professional who helps support emotionally, in some ways physically, in terms like when we talk about like non-medical like pain management, meaning like I would do like counter pressure, massage, those sorts of things for a person who is experiencing labor. So I support emotionally, in some ways physically and educationally, for pregnant and birthing people in both the prenatal experience, the birthing experience, and the postpartum experience. Yes.
So it sounds like you are the perfect coach to an often stressful part of that's associated with pregnancy. How come doulas aren't offered to every pregnant woman?
I think that there's been a lot of, I'm trying to choose my words carefully here.
Oh, take your time.
I think that the idea of a doula is kind of presented to much more privileged people. So, like, we saw a lot of celebrities talking about their doulas and, people with a higher kind of socioeconomic status and especially white women talking about the privilege of having a doula. And so because of that, because of the way like that the doula profession hit the mainstream, I think that it appears really inaccessible to a lot of people. And I want to be clear that that the right doula for you would not be inaccessible. Like, for instance, there are only 4 Black doulas that I know of in the state of Utah, and we all work on, like sliding scale basis for our clients because we understand that specifically Black women are the people who have been barred from the access, but who need it most. And so we're doing what we can to combat that inaccessibility.
Oh. What is the leading thought as to why Black women experience more maternal morbidity mortality than white women? And I know Dr. Decimo alluded to some of this, but could you expand on that?
I think that a big part of the problem is implicit bias. So I can just use the state of Utah here as an example. When women go and receive their prenatal care, if they have a provider that doesn't look like them, or for example, that doesn't look like me, there's part of being human where we all have these biases. And racial bias is one that a lot of people don't want to admit or don't feel like applies to them, but it's there. It's in all of us, and it's affecting the women who are having babies in this state. So I feel like a big part of that solution would be to have a provider that is like
Culturally competent?
Culturally competent,
Okay.
A provider that's culturally competent and aware of implicit bias, and aware of that potential within themselves. That way they can not project that onto their patients, or they can not let that affect their care that they're giving.
Or maybe just a provider that will just know from viewing this video here this afternoon that Black women have a 3.2 times chance of dying in childbirth.
Yeah.
And immediately thereafter than a white woman in this nation. So
Yeah.
I think that striking statistic hasn't reached everyone, and that's what we're trying to accomplish this afternoon.
Right.
I completely agree with that. And I would also add that, the racial biases aren't just, don't just happen on individual bases. I think that it's important to also acknowledge just the historical and currently structural and systemic biases that factor into the differences in maternal morbidity and mortality for majority and minority women. So, I think that healthcare providers need to do a better job of checking their biases, and I think the healthcare system has improvements that it can make in terms of just the quality of care that it's delivering to all their patients. But I think it's also important to keep in mind that there's kind of factors that are outside of the healthcare system that need to still be reckoned with in this country.
So would you say some of those factors fall under social determinants of health?
Definitely. I think that there are a lot of socio-demographic aspects that don't fully explain why there's disparities in healthcare outcomes, but they definitely don't help. So if you have a certain, portion of the population, a certain demographic of the population that has to deal with food insecurity or, unstable housing, difficulty getting to their prenatal care appointments, these are all things that won't help any situation in terms of having improved outcomes.
Okay. Would you say also access to medical insurance is a big factor?
Definitely. Access to care is another big one, and I think that falls under the umbrella of kind of socioeconomic factors that may contribute to different health outcomes. I think one thing that's important to mention is that for the state of Utah, there's a House bill that currently has not been passed, but hopefully in the future will get more traction, that expands coverage for women, especially in the postpartum period. So just acknowledging that once delivery happens, there's still considerable risk for women, and trying to cover them with healthcare through a year postpartum to try and mitigate some of that risk that they may incur during the postpartum period, which is just as important as during the pregnancy itself.
So even just through legislation, we could possibly lower the mortality rate, at least at our state level.
Hopefully.
'Cause this would benefit all women, not just women of color.
Exactly.
Where and with whom do women deliver?
So most women deliver in the hospital setting, and women deliver with OB physicians. They deliver with midwives. But some women also deliver in birth centers, and some women deliver at home.
Okay. What type of care or level of care can a midwife provide? Are midwives possibly a solution to these higher mortality rates with Black women?
I believe so. Midwives are able to spend more time with their patients and get to know their patients a lot more. Midwives have lower rates of C-sections, instrumental deliveries, so that's like forceps and vaginal deliveries. And I think that a big part of that is because midwives see birth as a natural physiologic process.
As opposed to
a medical procedure.
Would you say that's how many allopathic or MDs are trained?
I believe so. I think MDs are trained to take care of emergent situations, to fix problems, and so might not see birth as a normal physiologic process in the way.
Seeing as something that needs to be fixed.
Something that needs to be fixed. So baby's coming, and maybe we need to do something about that. Where I believe that the midwife training is more like, we'll let the process happen, and if there's something that needs attention, then we can collaborate with maternal fetal medicine and with the obstetricians.
And getting back to you, Ashley, as a doula, to be able to address Black maternal mortality rates, how does a doula advocate for a patient?
I think, at least in my experience, doulas advocate by empowering. So my goal is never to speak for or speak over a patient, but instead to empower clients to make choices, right? Also to ask the questions that they need to ask in order to make an informed and comfortable choice for themselves and for their families. And so a lot of times that looks like building a birth plan, right? Like that's like in a lot of ways, that's our very first step. We build a birth plan. What are your preferences? What do you want for this birth? I also go an extra step and have my clients build a birth vision. And the birth vision is much more like, what are the aesthetics of your birth? How would you like to feel? How would you like to be spoken to? What's the lighting look like? What kind of touch do you prefer? Because I think it's really important, especially for Black people in medical spaces, to realize that their experiences are their experiences and that they have ownership of those experiences, especially their birth experiences. And so that even if they're not at home, if they're even a high-risk pregnancy, right, in a hospital, that they still have choices about how their experience can go, and how their journey can go.
Will most insurance plans cover doulas, maternal fetal medicine doc, and midwives?
Most insurance plans will cover maternal fetal medicine docs. And now most insurance plans will cover a midwife. Most insurance plans will not cover a doula. And capping back onto when you were mentioning legislation, one of my big dreams would be if insurance or Medicaid and specifically would cover doulas as part of the birthing process.
So it seems like having a doula is, one, it's benefiting the privileged white population within Utah. It seems like it would almost be beneficial if every OB, as part of a birth plan, because I'm sure OBs do birth plans as well,
Right.
and midwives to always offer, but I guess maybe they're not consistently offering because it's not consistently covered.
It's not consistently covered. It's usually something that has to be paid out of pocket,
Okay.
which makes it not
Can I-
accessible to everyone.
Can I
Yes, Ashley.
here? A lot of women of color and Black women here in the States are either uninsured or underinsured, I would say. Having a doula can seem really inaccessible because we're paid out of pocket. We're not contracted by a hospital or a provider. We're hired by private clients. And so that's a barrier, right? Like finances are always a barrier to equity and care. And this is one of the best instances of that. And so I'm with Jalan, and I would love one day for us to have legislation which sees, doulas as a valuable and active part of a care team.
What is being done, Dr. Decimo, to address the outcome disparities between Black and white? And even better, if you can give an example of what University of Utah is doing. So just generally, and then, what is U of U Health doing to address this?
So, one big initiative is making sure that hospitals are providing a certain level in terms of quality of care across the board. There's good evidence that, depending on where you deliver, which hospital system you deliver in, your risk of having morbidity or even mortality as it relates to your pregnancy can be higher. And that's been highlighted in Black community as well. So in predominantly Black serving hospitals, the rates of morbidity and mortality in some of them have been shown to be higher. So one big push is to kind of equalize care across the board. And one way that's being done is through what's called care bundling. So if you have a certain condition, there's just a certain protocol in place to follow, a protocol that is kind of nationally standardized, that doesn't really allow room for potential implicit biases, in hopes to optimize the available resources and just make things standard across the board so there's not just significant disparities or discrepancies between hospitals.
So hospitals and health systems can take I guess a lion's share of this effort because that's where the majority of deliveries are still occurring as opposed to at home or a birthing center. How can a midwife help to address this disparity between Black and white as part of the care team?
I think a midwife can address this by receiving implicit bias training themselves, being educated about what's happening in our communities, being educated about this historical racial history that we have in this country, and look within and identify things that maybe they're holding within themselves that they're not aware of, and make sure that they provide equal care to all of their patients.
So for our providers in the state that are hearing this and listening to this, particularly say members of the Utah Medical Association, the largest physician group within the state, many of them are non-BIPOC providers. What do you think is the biggest thing that they can take from this, they should take back to their practice or their health system? Because all of us went into medicine because we want to ease suffering, increase length of span of life, and decrease pain for people.
Right.
What can a non-BIPOC provider do because many times it's not, and I'll get to this later, not every Black patient will have the opportunity to see you, Ashley,
Right.
And Dr. Decimo.
Right. I always say that one of my biggest worries is that people don't believe that they're contributing to this problem. The statistics show that people are contributing to this problem, whether they think they're racist or not, whether they think they have these biases or not. Just, we're all human. So just look within. I think just, we all need to look within. I need to look within. And so just take a look at ourselves and make sure that we're providing equal care to everyone.
Yeah, and I think it requires just a reorientation in terms of which patient populations you may be taking care of, in terms of reorienting your perspective. Mm-hmm. I think that, as a medical community, we've done a good job in terms of trying to take care of the opioid epidemic, and I think there's been a great push to try and provide those patients with resources. And I think if you apply the same principles to what's statistically proven to be a very high-risk population in terms of minority women, I think just having that perspective in the back of your mind, if you happen to be caring for women of minority backgrounds, can possibly influence outcomes. So I think that reorientation is important. And I also think that it's important for providers to be able to have those types of conversations with their patients, so that patients know that their providers are aware of these statistics and the fact that a certain patient may be high risk. And it's important for patients to know that, so that they're not discouraged with the healthcare system or with their individual healthcare providers. I think trying to establish a very open-ended kind of dialoguing, team-centered approach between healthcare providers and patients may also help the situation.
How do you feel having a Black healthcare provider addresses this maternal disparity right now in the Black community? And we can go with you, Jalon.
Well, statistics show that having a provider with the same racial background as you leads to having better outcomes. So I would love to see more Black midwives in the state and in the country, and more midwives to integrate care for women, collaborate care with maternal fetal medicine, and have a doula on board. I think that makes a big difference for everyone.
Yeah, we're all together. We're not working against. There's plenty
Right.
of this pie for everyone to have to improve mortality rates across the board.
Right.
Dr. Decimo, how do you feel having increased number of Black healthcare providers affects this issue?
Yeah, I definitely agree. I think that if you have someone that representation matters, so if you have someone that looks like you, the research and the evidence has proven to show that can improve outcomes. I think that it's also important to have people who this issue may be very germane to, or just it's very relevant. So, as a Black physician, this is something that I can't ignore. It's something that I want to understand to try and improve and change outcomes. So I think having that diversity within the field, hopefully there's a larger workforce of people that just maybe inherently more interested in solving these problems. And that's not to take away from all the great non-minority providers that are passionate about this subject. But I just think having a diverse workforce helps.
And would you agree as well, Ashley?
Yeah, I definitely agree. And I think there's a lot to say, Blackness, right, is not a monolith, but I would say that overall, right, a lot of us have a lot of experience with what it means to advocate for ourselves and for our loved ones. Historically, in in a racist medical system. And so I think having that experience and cultural relevance is also really important when it comes to how we interact with our clients and our patients.
You referenced sub-Saharan Africa and how their maternal mortality rates are significantly higher than ours. But But we are a developed nation, and compared to other Western countries, I'm sure there are those that are exceedingly doing much better in regards to survivability during pregnancy. And let's say possibly many Northern European nations are doing far better than us when it comes to OB or maternal care. What are some of the reasons why you think they're successful, and do you think that can be implemented here?
I think there are a number of factors. I think probably, primarily would be just the healthcare systems at play in different countries. So if you have a system that's committed to providing some type of access to everyone, I think
Universal coverage.
That is going to have an impact on your outcomes. So I think that first and foremost probably explains some of that discrepancy. And I think also very importantly is that some of these countries don't have to deal with the history that the United States has to deal with in terms of some of the vestiges of past racism and segregation that may now be playing out as we see it in terms of healthcare disparities and discrepancies in outcomes. So I think that there's some change that we can make on a healthcare basis, but I also think that it's important to contextualize some of the difficulties that we face and how our situation may not be the same as other European countries.
But we could take some clues, such as when you had mentioned about hospital quality standardizing across the nation, such as what's done with some of the more homogeneous systems of Norway and Sweden and the Netherlands. Do you feel that's something that we could do here, maybe if there wasn't so much a fixation on profit in medicine?
Definitely. I think that it's hard to operate in a system that optimizes profits over health. And I think that it's not specific to the healthcare system in and of itself. I think just society at large, it seems like, the profit motive is what drives most things. So instead of trying to have healthy populations and prevent chronic disease, we just fix things on the back end because it's more profitable to fix things than it is to prevent things. So I agree with that.
So in closing, I want to thank you, Dr. Decimo, Jelon Fall, Ashley Finley, for making time for us this early evening. But most importantly, I want to thank University of Utah Health, particularly the Department of Maternal Fetal Medicine and OB-GYN, for giving us access to these brilliant providers today, but also for giving Black physicians of Utah a chance to address this very important topic. This will be not the last time this will be discussed, and it's going to take an effort of all our allies to not only improve maternal mortality rates across the nation, but to address particularly those of Black mothers within our state. Our state's going to keep browning, and we need to do what's best for our Utahns. All right, thank you, everyone. Have a good evening.